Carpal tunnel syndrome. Carpal tunnel syndrome was first described by Sir James Paget in 1854, but the term was coined by Moerisch. Anatomy. The carpal tunnel is bounded by bones on three sides and a ligament on one side. The floor is an osseous arch formed by the carpal bones and the roof is formed by the transverse carpal ligament. Contents: tendons of flexor, digitorum, superficialis and profundus in a common sheath, tendon of flexor, pollicis, longus in an independent sheath in the median nerve. Synovitis of the above tendons can generate pressure on the nerve. Causes: general inflammatory-e.g. rheumatoid arthritis, endocrine-hypothyroidism, diabetes mellitus, menopause, pregnancy, etc. are some of the important endocrine causes. Metabolic: cause-gout. Local: these cause crowding of the space. Malunited Colles fracture, ganglion in the carpal region, osteoarthritis of the carpal bones, and wrist contusions, haematoma, etc. are some of the important local causes. Mnemonic: PRAGMTIC for causes of carpal tunnel syndrome. P. Pregnancy. R. Rheumatoid arthritis. R. Arthritis degenerative. G. Growth hormone abnormalities. Acromegaly. M. Metabolic: gout, diabetes, mycoedema, etc. T. Tumors. I. Idiopathic. C. Connective tissue disorders, e.g. amyloidosis. Clinical features. Stage 1. In this stage, pain is usually the presenting complaint and the patient complains of characteristic discomfort in the hand, but there is no precise localization to the median nerve. There may be history of morning stiffness in the hand. Stage 2. In this stage, symptoms of tingling and numbness, pain, paresthesia, etc. are localized to areas supplied by the median nerve. Stage 3. Here the patient complains of clumsiness in the hand and impairment of digital function, etc. Stage 4. In this stage, sensory loss in the median nerve distribution area can be elicited and there is obvious wasting of the thenar eminence. Clinical tests. These are provocative tests and act as important screening methods and as an adjunct to the electrophysiologic testing. Wrist flexion, Fallon's test. The patient is asked to actively place the wrist in complete but unforced flexion. If tingling and numbness are produced in the median nerve distribution of the hand within 60 seconds, the test is positive. It is the most sensitive provocative test. Fig. 19.55. It has a specificity of 80%. Tourniquet test. A pneumatic blood pressure cuff is applied proximal to the elbow and inflated higher than the patient's systolic blood pressure. The test is positive if there is paresthesia or numbness in the region of median nerve distribution of the hand. It is less reliable and is specific in 65% of cases only. Median nerve percussion test. Fig. 19.56. The examiner gently taps the median nerve at the wrist. The test is positive if there is tingling sensation. Seen only in 45% of cases. Median nerve compression test. Fig. 19.57. Direct pressure is exerted equally over both wrists by the examiner. The first phase of the test is the time taken for symptoms to appear, 15 seconds to 2 minutes. The second phase is the time taken for the symptoms to disappear after release of pressure. Other tests. 2-point discrimination test. This test is positive 1/3 cases. Electrodiagnostic tests are not totally infallible, with 10% individuals having normal values. Treatment. Non-operative methods. In the initial stages, non-steroidal anti-inflammatory drugs (NSAIDs) are given. If it is unsuccessful, steroids like prednisolone for 8 days, starting with 40 mg for 2 days and tapering by 10 mg every 2 days, are tried. Use of carpal tunnel splint is also advocated. Fig. 19.58. Physiotherapy measures thermotherapy using ultrasound. SWD helps to relieve pain. Exercises: gentle relaxed passive movements, active assisted and active movements of the wrist and fingers area indicated. Treatment of the underlying disease is of utmost importance. Splints: carpal tunnel splint helps. Injection treatment: this is indicated in patients with intermittent symptoms, duration of complaints less than 1 year, and if there is no sensory deficits, no marked thenar wasting, etc. In the injection therapy, a single infusion of cortisone with splinting for 3 weeks is tried. Surgery: this consists of division of flexor retinaculum and transverse carpal ligament and is indicated in failed non-operative treatment, thenar atrophy, sensory loss, etc.